Hi, good morning, everyone. Welcome to the first ASPA virtual meeting, and good morning from Singapore. We have an exciting lineup for you this morning. I'm Angela, consultant pediatric anesthesiologist at KK Women Children's Hospital, Singapore. I have with me Dr. Ayten Sarakoglu, co-moderator of this session. She's a professor at the Medical School of Marmara University, Istanbul, Turkey. She specializes in neuroanesthesia, cardiothoracic anesthesia, as well as heart and liver transplantation. Together, we bring to you the cardiac track of ASPA 2021.
Good morning, everyone.
Good morning.
Thank you very much for your nice presentation, Angela.
There are two segments to this track. In the first, we will explore the future of cardiac surgery in Asia with Dr. Taylor and Dr. Rao. We will then dive into the realms of viscoelastic testing with the other three speakers. The speakers will answer your questions at the end of the relevant segments. If you have questions for the speakers, please click on the live discussion button at the bottom right-hand corner of your screen. The live discussion panel will pop up. On it, enter your questions under the Questions tab. Without further ado, please allow me to introduce Dr. Rao and Dr. Taylor. Dr. Suresh Rao is the lead pediatric and cardiac and congenital heart surgeon and director of the Children's Heart Center, Kokilaban, Dhirubhai Ambani Hospital and Medical Research Institute of Mumbai. He was formerly the president of the Indian Association of Cardiovascular and Thoracic Surgeons, president of the Pediatric Cardiac Society of India, and is a diplomat of the National Board of Cardiothoracic Surgery, New Delhi. With him is Dr. Taylor, consultant and chief pediatric cardiac anesthesiologist and intensivist. He has 18 years of experience in the field of pediatric cardiac anesthesia and intensive care. His interests are in pediatric cardiac ECMO, pediatric heart transplant, and ICU. Jointly, they will share with us the challenges of the congenital heart program and how they overcome some of these. Thank you, Dr. Taylor and Dr. Rao. Please take.
Good morning, ladies and gentlemen. I'm Dr. Suresh Rao from the Children's Heart Center, Kokilaban Dhirubhai Ambani Hospital, Mumbai, India. In the next few moments, I'll be speaking to you on how we have converted a challenge into an opportunity of a congenital heart program in a resource-limited environment. As you all know, India has got a huge population of 1.3 billion people. And whatever gains has been done in the increase in GDP has been neutralized and diluted by the increase in the population, leading to poor health indices. And health is a low priority for us at the moment compared to many other countries, as you can see here in the developed world. And only 1.28% of our GDP expenditure is still on health. And it's much lower than many other countries. Even if you see the health expenditure, it's only 3.4% of the government-generated health expenditure, and more than 60% of our population have to pay out of their pocket for medical expenses. Though much advances has been made in the reduction of infant mortality and neonatal mortality rates, as you can see, that's in infant mortality. Now we are about 40 per 1,000 births, and neonatal mortality is less than that. Much over the last 20 years, it has come down. Still, a lot needs to be done. India is a land of contrasts, and where you can see one of the states, Kerala, has reached the developed country levels, but then there are other states which are woefully lagging behind. And congenital heart disease today forms around 10% of the infant mortality rate seen in India. So there is a paradox when we have centers of excellence, good medical skills, knowledge, infrastructure, and we are a major center for medical tourism. We still have shortfall in the nursing and paramedical staffs, unaffordability despite reasonable charges, no universal health insurance, pretty bad state of the government hospitals, inadequate manpower, and most of the congenital heart programs are in the private sector. So that gives us a problem of sustaining these programs and with subsidies and new technology costs adds to the problems. And if you can see here, if you hemisect India into east and west, you'll find the east of the line, that's on your right side, there are hardly any centers, and it's more concentrated towards southwestern part of India. So what's a low resource environment? Well, it is an environment where there's a large unaffordable population paying out of their pockets for their care, with a lot of constraints in nursing, personal, technology, availability of hardware disposables, and more constraints in number of days of hospitalization, economics, if there are more complications and overstays. So this poses a lot of challenges due to the large number of patients, late referrals, low birth weight, poor nutrition, antibiotic resistance, coupled with limited resources, a lot of competition for the small amount of resources, and all the facilities are stretched to a maximum. Technology and practices continue to be needed to keep pace with scientific advances, but all of them have a cost. So is congenital heart lesion a priority, you may ask me? Well, the obvious answer would be no, but I would like to differ on that count, because congenital heart disease is an increasing proportion of neonatal and infant mortality rate. There is a large and burgeoning affording population demanding the best of holistic healthcare in this country. So it is becoming more and more pressing on us that we do offer world-class services for congenital heart surgery and corrections. What are the requirements for developing a congenital heart service? Well, in India, the reality is that it should be a system of charitable care, sustainable systems, education, training with ethical practice, which is not totally profit-driven. So as you all know, a dedicated congenital heart program is extremely resource-intensive with multidisciplinary specialists which are needed. We need trained staff with good remuneration, good opportunities for growth, and all other ancillary specialties. So all these are more daunting and challenging in a developing country like India. So how did we convert these challenges into an opportunity? We are a corporate social responsibility initiative from a large business group in Mumbai, India. And how is the surgery paid for in this country, as you may ask me? Well, we have two extremes. One is there are centers which are doing absolutely free surgery for children, and those have tried to have the other extreme, of course, is completely paid for. But then most of them are in fixed closed-end package costs with subsidy from the hospitals and the governments for below the poverty line people. Now we do have a government insurance called Ayushman Bharat and RB. It's a scheme for all the children, which are gradually being doled out to most of the population. So to make it happen in our center, the primary problem we had to find is funding and the need for subsidies, because government funding does not meet the costs at all. So we had to go about finding funding from private charitable NGOs, CSR organizations, and make it more affordable for out-of-pocket expenses if that had to be paid. And we did have very many neighboring patients who made possible surgery for their other children. So adequate funding was needed to meet the reasonably fixed packages needed for sustenance of the program and provision of quality care, because as you all know, congenital heart surgery and the care of the congenital heart disease child, we cannot make any compromises in delivery of quality care. So if you take an example of a tetralogy of fallow correction, which costs around $5,000 in our hospital, the hospital subsidy itself comes to about $1,000, with other subsidies from Rotary or NGOs from $2,000 to $4,000. Charitable organizations or even government expenses comes to about $2,000 to $4,000. Other charitable organizations and what they co-pay, if it is possible by them, is around $400 to $1,000. So it is incumbent on us to reduce the cost of care, and these are all the major measures that we have taken to see that it's more affordable to our population, particularly good ID practices, antibiotic decisions, and selective reuse of the disposables, and avoid wasting of these items. Other practices, my colleague, Dr. Kamlesh Taylor, will be telling you about early extubation practices in our ICU. So a low resource environment must have all these gadgetries and also these infrastructure, and which are necessary for carrying out our specialty. But of course, the most important thing is simple things can yield great dividends, like hand washing, simple ID practices, protocols, and all that. So there are some luxuries which we would like to have, but then sometimes you may not be able to afford it. But of course, we try our best to gradually acquire this. One is optimal number of trained nursing staff. We're always short on that. Optimal number of senior specialized and medical paramedical person. They're always short of the trained people. And certain technologies like nurse, ECMO, costs a huge amount of expense on the program whenever we decide to use it. So what are the challenges in running the program? One, the financial sustenance of the program, maintenance of desired quality, nursing turnover to better pastures is a huge problem we are anticipating with no solution in sight. And of course, what takes the cake is sepsis and overstays for whatever reason more than the prescribed stay in the hospital. So we have combated these challenges by creating a good environmental working environment, a pride in our team where everyone is important. Simple, inexpensive methods of infectious control like hand washing and ICU discipline has yielded great dividends in reducing the cause of sepsis and overstays. The good surgical techniques, of course, has reduction of blood products, pharmacies, good communication, use of technologies, and all these have helped us in coming to terms and delivery of care with reasonable costs. And surprisingly, what we find is remuneration is secondary to most of the above. But I think what is important are all the points which we have noted earlier. So what is the future for congenital heart programs in this country? I mean, in this country and perhaps in the neighboring countries, also in Asia. One, I anticipate that the growth of congenital heart surgery will be tempered by the impact of fetal echocardiography, which is slowly catching up, and more pregnant mothers will be screened, and perhaps they may undergo termination of more complex heart problems. So the growth of congenital heart numbers might be tempered by this. Congenital heart disease, already as has been shown in India, is forming more and more percentage of infant and neonatal mortality. So therefore, the need for the services will be there. Currently in India, we should be doing around 150,000 surgeries per year, but we are barely able to touch about 40,000. So at least in the foreseeable future, there will be the need for many more centers and also many more surgeries and corrections that need to be done. We are beginning to see an interest in private health insurance. I hope it just comes around, which will benefit a lot of middle class people who can't afford the current costs. Universal health insurance for all is a fervent hope that we all have, and the government is working towards that. We are beginning to feel the need for an adult congenital heart specialty, and as most of our children who are growing into adults, they will be coming into this category, and we will be seeing more and more adult congenital heart centers coming up. And likewise, even heart transplantation for congenital heart disease is going to be seen more and more, and the need is going to be felt in the future. I would like to acknowledge all the contributions made by my team in Mumbai. And thank you very much for your attention and giving me this opportunity to present whatever we are doing in our center to you all. Thank you.
Good morning. Myself, Dr. Kamlesh from India, Mumbai. I like to thank Dr. Sahani and organizer for inviting me for the event. In continuation of Dr. Rao's presentation, I like to highlight few of the outcome and points related to this theme. When I'm speaking about Mumbai, there are two classes of people stay in Mumbai. One is one group of people, they daily struggle to survive, and the other group of people, they're super rich. In between those two, there are middle class who comes to Mumbai to fulfill their dreams, and that is why Mumbai is also called as City of Dreams. Where I'm working, it's Kokilabin Dhirubhai Ambani Hospital and Medical Research Institute. It is 850-bedded multi-specialty hospital. Few years back, we have completed 10 years of a hospital. Our hospital is JCI and NABH accredited. Children's Heart Center, where I am working, has completed 12 years in September 2021. We are performing around 1,000 or more than 1,000 cases per year. On an average, around 100 to 120 procedures per month, includes 60 to 80 surgical procedures, 30 to 40 cardiac catheterization and interventions, and 30 to 40 around CT scan MRI. So on an average, we are having a high volume center in this part of the country. We are tertiary care center we got a lot of referral for the complex congenital lesions. This is our last 10 years of our surgical cases number. Last 2 years slightly reduced because of COVID, but last few months we again regain our pre-COVID workload. The main problem in India regarding the congenital heart specialty is the financial crunch, which Dr. Rao already have mentioned. Now, the few of the points regarding this will be, because of this infants having young couple, they don't have any savings left with them, and that is one of the major reasons to a financial problem in this kind of specialty. We don't have insurance cover in this part of country. Government scheme also only cater to below poverty line, and that is why we are having struggle of maintaining cost, viability of the program, and reducing overall kind of surgical expenses. Whenever we are having this kind of a problem, we'll try to cut down our cost without compromising our quality of care, and sometimes we ask for a financial help. 50% of our surgical procedures are funded either by government scheme, NGOs, or charitable trusts. This is a subset of our group of patients. Since this is last 6 months data, we perform around 10 to 15% of infants in every month, and around 50% of our caseload are less than 6 months. Same regarding the weight also. We perform around 15 to 20% of our cases less than 3 kg, and around 40 to 50% of our caseloads are less than 5 kg. With this all complexity and difficult surgeries, we are able to maintain our ventilation time, and this is last 10 years of data. We try to reduce our ventilation gradually by year. Same way, a slow and steady improvement in reduction of our ICU stay also. Our constant fight with infection will always be there, especially in this part of the world. This is 5 years of data regarding the bloodstream infection. When we started around 5 to 6% of infection, now gradually will come down to around 2 to 3%. Same way, ventilator associated pneumonia also, when we started it was around 4 to 5%, but now we are able to bring it down to 2%. Our surgical site infection also has come down to around 2.5%. Our mortality is around 2 to 3%. When we started, it was around 5 to 6%. This is our last 8 years of data of mortality. In spite of having complexity, we are able to bring it down to the 2 to 2.5%. So the main reason for our mortality is we are one of the tertiary care of a center. So we got most of the complex cases, and sometimes we cannot able to defer those cases, and we have to operate. We are having a delayed transfer because of late pickup, or because of some other reasons, or sometimes financial reasons. We have a late presentation, as Dr. Rao already mentioned, that only 10 to 15% of our pregnant ladies undergoes fetal echocardiography, and that is why some of the cases are being presented late. We are facing a problem with the preoperative sepsis, and sometimes, as I mentioned, we have some cases where we have postoperative sepsis also. Many of the patients are associated with malnutrition, and which is also affecting our outcome. And we are having high nursing attrition rate because of less number of nursing staff, and many of the nursing staff like to go outside country to earn higher amount of money, which we cannot able to match. We are associated with many national and international agencies. We are having a teaching programs like cardiac anesthesia fellowship programs, pediatric cardiac surgical fellowship program, pediatric cardiology fellowship program, pediatric cardiac ICU fellowship program. We are associated with ECMO Society of World, and we are associated with Boston Children in their program of IQIC. We are having academic meetings and quality meetings to maintain our quality and academic balance of the unit. We know that cost is very important, but one of the means to reduce the cost is quality, and that is why we have taken a bold step to adopt ARAS program in our unit. ARAS program is a multi-modal, patient-focused, evidence-based, interdisciplinary approach. This aim to reduce the overall ICU stay and hospital stay. By implementing this ARAS protocol, we can able to reduce 30 to 45% of hospital stay by reducing the complications, surgical and non-surgical. And by this, we can able to reduce 30 to 40% of our overall healthcare cost. With adopting such kind of program, we will able to increase our turnover, and with the same infrastructure, we can able to serve more number of patients. It's a multimodal program where early mobilization, reduce ICU, and hence it can cause reduce hospital and ICU stay, and overall it will reduce the cost. But we like to mention here that we don't want to compromise our quality of care by adopting such a program. We have multiple meetings and discussion, and last almost 1.5 years we are implementing in simpler cases. So category 1 and category 2 are simpler cases where we able to extubate early, and by extubating early we able to reduce ICU stay also. So almost 171 cases, almost 60 to 65% of cases, which are simple cases, we able to extubate on table. Other modifications related to the reduction of cost is in the ECMO kind of a circuit. We are having active pediatric cardiac ECMO program, and last 7 years we are able to perform 70 cases with 60% discharge to survival incidents. So in around few of the cases, we modified our circuit to reduce overall cost. Total initiation of ECMO cost in this country is around 2.75 lakhs, that is around $35,000. We are using all oxygenator and pump which we are using inside the theater with the same kit. Sometimes we extend it to the ICU and continue as a ECMO. By this modification, we are able to reduce the ECMO cost by around 60 to 70% overall. We compare our results, 26 number of patients we are performed with this modifications. We compare the other group of patients, which is rest of the cases, and our results are comparable. Few of the limitation is there regarding this modification. So it is not ideal to long-term ECMO supports. So we are learning our best with few modifications and few of the bold steps. We believe that it's a teamwork, and teamwork can only make us a dream work. We believe we don't limit our challenges. We have to challenge our limits. We like to open up the new windows to explore new territories. And we believe that quality is not an it's a habit. Thank you so much for being a part of this event. Thanks.
Hi everyone. Okay, I would like to invite Dr. Suresh Rao and Dr. Kamlesh Taylor on stage now. Thank you very much for your very insightful talks. I've learned much from your presentations. Dr. Rao, I have a question for you. It seems like managing resources has been a challenge. And how has COVID actually affected this in your hospital?
Thank you, Angela. Before answer, can I say thank you to Dr. Jay Shahani, who is principally responsible for having me on your program. To answer your question now, human resources has been the most difficult. You know, in the peak COVID times, we had nurses falling ill. They were not able to come back for duty, doctors falling ill. So they have been a great challenge. Supply chain, this one, all disposables, because most of the disposables are imported. So we were not getting these. And more important than this was we had 5 children who tested negative when they were admitted, but in the course of hospitalization tested positive. And of which 2, unfortunately, we lost them in the course of post-operative recovery. But 3 of them we could salvage in the COVID ICUs and with the suboptimal care compared to the normal pediatric cardiac ICUs. So that was a huge challenge. And of course, the last one was funding, because when all the NGOs, they depend on funding from foreign sources. So when COVID was, it's a pandemic, so even that sort of dried up. So it was indeed a challenging time to sort of uh, go on with the program, but then we did manage somehow, and it's easing up now.
Oh, that's great to hear. So the two that you lost, was it related to COVID, or was it?
Yes, both of them were infants. We as a policy, we all test them before we admit the RT-PCRs. They were negative, but then in the course of the hospital stay, they were not going the way we wished them to do. So there was something amiss. So when we retested them, they were positive, and afterwards they manifested full-blown COVID pulmonary complications. You know.
Right. So when resources were poor at this point in time, how did you all cope?
Sorry?
How do you all cope when the resources were poor at this point in time? Did you all have to come down on surgeries and had to be
Yes.
postponed?
Well, I think in the middle of 2020, when the pandemic was at its peak, and also the second wave, we did have a sort of shortfall in the elective cases. But then we have been doing all the emergencies all along.
Right.
They have been coming, and particularly the arterial switches and the neonatal TAPVCs. They were the ones which we have done maximum.
Right. Okay. Thank you, Dr. Rao. Thank you.
Welcome. It's a pleasure.
Thank you very much. Dr. Taylor, we have a question for you. It's we also have an interest in ERAS as well as early extubation. Can you elaborate more on how ERAS is implemented, and are there specific techniques that you use to enable early extubation?
Thank you, Dr. Angela, and thank you, Dr. Haitin. So we implemented ERAS as a part of a protocol. It benefits in many of the way because it reduces our resources, but at the same time we like to have a safe mode also. So but before implementing ERAS, we have a team approach. It's a multimodal team approach where each part of a team member is been involved. So we have a meeting with surgeons, we have a meeting with anesthesiologist, we have a meeting with intensivist, perfusionist, and even the nursing staff. And we jot down the points where we were lacking. We have planned it where we can fast track with safety keeping in mind. One of the part of ERAS program is fast tracking. So we discuss amongst anesthesiologists and decide about how to go ahead with fast tracking. So we avoid implementing in complex cases for initial period. Still, we are in initial phase only. So we have implemented only in category 1 and 2, which is a reg category, where only simple ASD, VSDs are being extubated on table. And as a part of a fast tracking, the few of the modifications we have done. Initially, we used to have a higher opioids uses throughout the pediatric cardiac surgery. Our uses of fentanyl, something around 10 to 15 mics per kg in a total one surgery. We cut down significantly by adapting other mode of analgesia.
Okay. We might have lost Dr. Taylor for a while. We just wait for him to come back online.
Sorry. Yeah.
So
Am I audible? Yeah. So we are adapting caudal analgesia to replace and reduce fentanyl uses during the surgery, and by we can able to reduce the use of fentanyl and opioids by almost 80%. We are using more of multimodal pain and we are using fast track methods where we are using short acting muscle relaxants. And yes, we are using inhalation agent to reduce our overall kind of opioid uses.
All right. Thank you. With respect to the use of your caudal, do you do it? What age groups do they do it for? And do you have adjuncts in the caudal?
Sorry, the age group is Yeah, so we are using something around up to 15 to 20 kg, up to.
Attention please. This is a
Sorry,
reminder
one
to keep your
announcement is there
mask
in my
on
hospital.
at all times and use hand gloves.
Yes, I apologize. Thank you.
लगभग अपने मास्क पहले रखें और अपने हाथों को हर 1 घंटे धन्यवाद।
Okay, we'll just wait for that announcement to pass and we'll
Yeah,
have Dr.
so we are using cordon up to 20 kg or some around 2 to 3 years only. And most of our patients are subset of around less than 10 kg most of the time. So we are able to put the cordon in most of the cases where we are doing a fast tracking. What was your second question, please?
What do you use for what drugs do you use for the caudal? Are there any
So we are
drugs that
using, yeah, we are using clonidine 1 to 2 mics per kg. In with the clonidine, we are using morphine 100 mics per kg, and volume we are using 1.5 to 2 ml per kg.
Oh, okay, okay. And do they use this for all surgeries or only those ASDs and BSDs that you fast track?
Only those who are doing fast tracking, because some of the cases which very sick with deranged coagulations, so we like to avoid such kind of cases where we are going to have a fully heparinized post-operatively also they will have a lot of coagulopathy. So we'll try to avoid, we are using only with those who want to extubate and having a fast track mode.
Great, thank you. I think we have time for one last question, and I would like to direct the question to both of you. We have a question of what kind of data do you track for quality management?
Ramesh, would you like to take it?
Yeah, so we are having a very broad methods where we are keeping a quality check. We are having a we keep tracking our monthly ICU data, where we are seeing that obviously morbidity and mortality we are divided into these two groups. In morbidity, especially when we are seeing it ventilation time. How many patients in RAS protocol is it is falling a place where we are started. Second thing we are tracking is reintubation rate. We are using a lot of non-invasive ventilation after extubation, especially in neonates. So we are tracking how many patients are being used for the non-invasive ventilation, because we are adopting early extubation even in the neonate, but those cases we require non-invasive ventilations. So we are tracking that. One of the very important factor in this part of country is sepsis. So we are tracking all kind of a sepsis, blood sepsis. We are tracking WEP. We are tracking SSI also, and we are having a antibiotic stewardship program. So we are tracking all our higher antibiotic uses, whether we can de-escalate is as early as possible. So this is one of the aspect of tracking. We are tracking when we are taking back to the theaters sometime, or we are readmitting any patients after discharging from the ICU, including ICU stay. These are the very important kind of parameters why we have setback. So these are the parameters we are tracking in association with CPR, near misses, and open sternum cases. And then yes, if there is a mortality, we are individually discussing within the team and find out what could have been done better to prevent such kind of mortality.
Is your data collected in a national level or within your hospital?
So there is no national data collection, unfortunately, in India, because most of the sector, as Dr. Rao also has mentioned, is they are corporate hospitals, and still there is no national records available or any platform where we registered our data. So as a part of tracking our own data, the Boston Children has the initiative of it is called as IQIC, where they are collecting all those countries' data where they are in developing phase or their program has been just started in a developing phase. So our data has been shared with Boston Children, and they analyze our data and compare with other countries, neighboring country, and we will able to see that where we stand in this quality and mortality and morbidity parameters.
Right. Okay, thank you very much. Thank you for all that information. It is a pleasure to have you guys on with us, and thank you for sharing what you do in your hospital. I'm sure the attendees will benefit from it. Okay.
Thank you very much.
Thank you all. I will now hand the time over to Dr. Aiton, who will introduce the speakers for the next segment of the talk. Dr. Aiton, please.
Thank you very much, Angela. And hi, everyone. Hi from Istanbul. And I would like to thank organizing committee, first of all, for their kind invitation. And I would like to present you a great speaker with comprehensive topic, Dr. David Favaroni. And if we talk about his research and publications, we cannot have time and cannot finish during this session. And just briefly, I would like to give some information about him. And after he graduated from University of Brussels, he completed his residency in the same university. He became assistant professor till 2014. And following, he completed his PhD thesis about perioperative management of bleeding in children undergoing cardiac surgery. He started his fellowship in hospital for 6 children. Then he promoted as an associate professor in Toronto University. And he is currently working in Texas Children's Hospital as a professor. He is associate editor for anesthesiology, anesthesia and analgesia, and pediatric anesthesia, and many other journals. And please, Professor, now time is yours. Thank you.
Hi, everyone. It's a great pleasure to be here with you today to discuss factor concentrates and the use of viscoelastic testing in pediatric cardiac patients. I'll mainly focus on the use of factor concentrates because I know we have other fantastic talks on this session on viscoelastic tests. So I'm really going to tell you about the use of viscoelastic tests to guide the factor concentrates. And I suspect in the discussion at the end of the session, we can put everything together and have a discussion with the other speakers. So I don't have any financial conflicts of interest. What I'm going to try to do with you today is to discuss the use of factor concentrates in pediatric cardiac surgery. We'll talk about the studies on efficacy and safety. And as you know, the pediatric literature is sometimes really poor, and we'll have to talk about some adult studies as well. And then we'll talk about the evidence and what remains to be demonstrated. So when we try to treat coagulopathy in pediatric cardiac patients, what we are trying to achieve is achieve hemostasis intraoperatively. And we all know our patients are bleeding. We all know our patients have sometimes receiving a lot of blood products. And we have to keep in mind that this process is actually a very dynamic process because our pediatric patients are also at increased risk of thrombotic complications later on. So when we decide what product to use, we have to keep in mind that we want efficacy intra-op, we want safety, and we also want a product that won't increase the risk of postoperative complications. And all those things will be taken into account when I'm going to present to you all the different options that we may have. So the way I see factor concentrates versus allogenic blood products coming from the blood bank is a little bit like you can see on those two pictures. If you like sugar in your coffee or in your tea, what you do is you take sugar and you add it to your coffee or your tea to achieve the sweetness that you want. I don't know many people that are actually using 2 different cups of coffee or 2 different cups of tea, one with sugar, one without, and mix them together to try to achieve this degree of sweetness. Most of us use the sugar that we have separately. And I think this is the idea behind the use of factor concentrate as well. If you are missing one of the factors, why would you use a product that contain not so much of any of the factors, and especially not the one you want? So what we'll try to do here and in the next couple of slides is to discuss the different options that we have. So this is usually how I summarize coagulopathy and how the different options that we have. In the red box, you see the platelets, and I'm not going to talk about platelets today because we don't really have concentrates for platelets or alternative to allogenic platelets. We have the box in the middle with the fibrin, fibrinogen, and I'm going to talk about the different options. We'll talk about thrombin generation in the blue box and the options that we have. And I'm not going to talk about fibrinolysis today because it is not the topic of the discussion. So let's start with fibrinogen. So we all know that fibrinogen and hypofibrinogenemia is a real issue when the patients are bleeding. And we know that fibrinogen is the factor that will decrease to a critical level the first when your patient is bleeding. And it's been demonstrated in 1995, which is now a long time ago. And even before that, that's something that people were aware of. We know, and we did that study a long time ago now, we know that hypofibrinogenemia is a risk factor for bleeding. It's been demonstrated in pediatric cardiac patients. I'm just using our data here with ROTEM and fibrinogen levels. There are many, many more studies in the literatures that are showing you that hypofibrinogenemia is a risk factor for bleeding. And therefore, we have to replace fibrinogen. The first statement I'm going to make about fibrinogen is that the use of fresh frozen plasma, it is not an option to supplement fibrinogen. Why? Because if you know what fibrinogen, FFP, and both have in common, is that they are both very close to water. And of course, that's a joke, but it's just to tell you that the issue with FFP, as I said with my coffee reference before, is that the FFP is yours or my plasma. The fibrinogen level is hopefully physiologic, but it's not supraphysiologic. So if I want to increase fibrinogen in my patients by using a pretty physiologic concentration of plasma, then I will need to give quite a bit of plasma before I can see an effect on the fibrinogen level. And this is shown here in this study from the British Journal of Hematology in 2004, where you can see that if you want to significantly increase the concentration of factors by using FFP, you have to give at least 30 milliliters per kilograms, which we all understand is a huge volume for our pediatric patients. So not really an ideal options or an options at all. So what do we have? Well, what do we have? We have other options. We have cryoprecipitate. The challenge with cryoprecipitate is that it's not available in every country anymore because many countries have decided not to manufacture cryoprecipitate. But if you do have cryoprecipitate is an option because it contains a higher concentration of fibrinogen. The one thing you have to keep in mind, though, looking at the right-hand side of my slide, is that fibrinogen concentration in different units of cryoprecipitate is highly variable. So it's hard to know how much you are giving when you are giving 1 unit of cryoprecipitate. Which brings us to the factor concentrate, which is fibrinogen concentrate, where you will give a dose knowing exactly the amount of fibrinogen that you are giving. Many, many countries have fibrinogen concentrate available. We can talk about challenges of using and adopting the use of fibrinogen concentrate in the discussion, but overall, we see all over the world an increasing number of programs that are using fibrinogen concentrate. And why so? Well, because we have some evidence, and there are a few randomized control trials, and I'm going to focus on this one published in 2019 in JAMA by Dr. Karkoudis' group in Toronto and Canada, who performed a large prospective randomized study, including several adult programs in Canada, and they randomized patients to receive either fibrinogen concentrate or cryoprecipitate. What you can see on these slides is 2 important statements. Number 1 is that the efficacy of fibrinogen concentrate is comparable to the efficacy of cryoprecipitate. So if you are using cryoprecipitate and you are thinking of switching to fibrinogen concentrate, you could expect that the efficacy of your fibrinogen supplementation will be the same. What we don't really know, and it's hard to study because the incidence of adverse events are pretty small, what we don't really know is that fibrinogen is safer or less safe than cryoprecipitate. But that being said, you have to keep in mind that when you give cryoprecipitate, you're not only giving fibrinogen, you're also giving other coagulation factors that you might not need in your patient. So I do believe that because cryoprecipitate is an allergenic blood product, and because it doesn't only include fibrinogen, you might see an increased risk of side effects if you have a really, really large cohort of patients when you compare to fibrinogen concentrate. Keep that in mind, but think that there's no evidence to support that. It's just my personal opinion. So what about the pediatric patients? Well, pediatric patients, we have a few studies that actually looked at fibrinogen concentrate. This is the first one from Brazil, from Filomena Galas and Ludmila Hajar in Brazil. So prospectively randomized patients to receive either 60 milligram per kilo of fibrinogen concentrate or cryoprecipitate. What do you see on this slide? You see that number one, the fibrinogen level was slightly higher, not significantly clinically relevantly higher, but slightly higher in the fibrinogen concentrate group. And overall, not much difference in terms of transfusion other than a slight decrease in the overall transfusion, as you can see on this bar here. What do we know else? Well, that's another study coming of the UK in London with Christina Siemens, who did a prospective randomized study that was called the FIPCOM study, which are very different design. So the design of that study was actually to monitor fibrinogen on bypass when the patients were getting rewarmed, and in the presence of hypofibrinogenemia, defined as a FIP-10 MCF low or equal to 6, the patients would be actively randomized, and so randomized between fibrinogen concentrate or placebo. The challenge with that is obviously that nobody gives a placebo to treat coagulopathy. Therefore, the results of the study are not giving us really what we want to know, which is fibrinogen better than the control that we have, which is in most institutions cryoprecipitate. But in any way, you can see that in that study, the fibrinogen concentrates obviously increased fibrinogen and that they were not reporting any significant side effects. So the best randomized control trial that we have so far is the randomized control trial from Dr. Downey in Atlanta, and also including a cardiac program at Stanford in the United States, where they actually randomized 60 patients to receive either fibrinogen concentrate or cryoprecipitate with the same type of design that we've talked about before. And what you can see is that the fibrinogen levels were equally increased with the use of fibrinogen concentrate and cryoprecipitate, not so many difference in terms of bleeding and side effects. So going into the same direction that what we saw with the large adult study in Canada, showing you that plasma cryoprecipitate is probably as effective as fibrinogen concentrate. And I do believe, as I said, that fibrinogen concentrate might be slightly safer than cryoprecipitate. All right, so we talked about fibrinogen concentrate, and I want to talk to you about now the use of agent that will increase thrombin generation. So we all know that factor 7A, NOVO7, was used for a long time in cardiac patients to increase thrombin generation and treat acquired coagulopathy. So what is the challenge with that? Well, the challenge with that is that factor 7A was not really designed to treat acquired coagulopathy. And when you give it to our cardiac patients or in any patients that have acquired coagulopathy, as you can see on this study, on this analysis published by Marshall Levy and George Levy in the New England Journal of Medicine back in 2010, there is an increased risk of thrombotic complication, especially arterial event. And that's not something that we want to see in our patients. We did look at the literature back in 2017. We did look not at the literature, at our patients when I was at Boston Children's Hospital. We looked at the patients who were getting factor 7A, and we compared them to a matched control of patients who did not get the factor 7. And you will tell me, oh, you are comparing apples and oranges, because those patients who were not getting the factor 7 were probably not bleeding as much as those who were getting the factor 7. And that's completely true. And that's why we did the match cohort. We matched them for all kinds of risk factors and variables that were associated with bleeding, just to make sure that we were comparing two groups. There is still a risk of bias, but overall what you can see is that the patients that were exposed to factor 7 had a significant increase, almost more than double increased risk of thrombotic complications. And the challenge with the use of factor 7 is that people don't really understand how and when to use it. And I think you have to remember that if you give factor 7A, the goal of factor 7A is actually to increase thrombin generation. But if you don't have a substrate, if you don't have platelets, if you don't have fibrin, the factor 7 end of thrombin generation is not going to help you form a clot. So you have to treat the coagulopathy, the platelets count, the fibrinogen, and make sure all the other factors are there before you start thinking about giving a product that will increase thrombin generation. The problem with thrombin generation is we do believe that there's an issue with thrombin generation in our cardiac patients, but it's not really what we find in the hemostasis literature. This is an example of patients who are underwent cardiac surgery, and you see the baseline thrombin generation rate and thrombin potential there. You can see that at baseline, the thrombin potential is high, which we expect. You anticoagulate your patients during bypass, the thrombin potential goes down, which we expect. I just want to highlight one thing here, which is that it's not actually going down to zero. There's still some thrombin potential there. But coming off bypass, the thrombin generation is actually high. There's an increase in the thrombin potential after protamine administration. So having a drug that will even more increase thrombin might not be what we actually need. There are some studies, and those are really very fascinating studies coming out of Nina Gizzera in Atlanta and Ashley Brown's lab in North Carolina. And they looked at how those agents like factor 7 or FIBA, which is some sort of a 4-factor PCC with activated factor 7A, can help you increase your fibrin network. And what we can see on this slide is, number one, when you give adult cryoprecipitate to a neonatal patient, the fibrin doesn't work so well together. And that's because those fibrins are different. So one of the options that you may have is to burst the thrombin generation and promote the clot formation, and therefore use the patient's own fibrinogen to form this better clot. So that's one thing that you might be able to achieve with thrombin generation. But again, keep in mind that safety issues are a real concern. Another thing that you might be able to do with thrombin generation agents is that thrombin is actually a very potent activator of the platelets. And there are some studies actually showing that thrombin will help you form a clot with the activation of the platelets. But there's also some studies showing that this might have there might be a time difference between what the thrombin can do on your platelets when your platelets are functional before surgery and when your platelets are dysfunctional after cardiopulmonary bypass. So it hasn't been studied very well in the pediatric patients, but in my opinion, this is something that might be of interest. Somebody should look at into how those thrombin generator agents can help you maybe activate your platelets and form a better clot. So those are the 4-factor PCC that you can find around the world. As I said, it's 2, 7, 9, and 10. The FIBA is with activated factor 7. And what you have to keep in mind is that this is not really studied very well. So this is a sub-analysis of the fiber study. You remember the Canadian fibrinogen study that I showed you before, showing it seems that when PCC was used, patients were getting transfused slightly less. It needs to be studied in a large randomized controlled trial, which I know is underway in Canada. And this is an example of the pilot study that they did before starting a larger randomized controlled trial. So I hope that in the future, we're actually going to have some data on the use of PCC, in this case, in adult cardiac surgery, and I hope in pediatric patients as well. If you remember one of my first slides and the dynamic component of treating coagulopathy, you have to remember in the first couple of days after cardiac surgery, our patients are prothrombotic and at risk of thrombotic complications. And if you look on the right-hand side here, which is a study that was not done in pediatric or adult cardiac patients, but in patients that were treated with direct oral anticoagulants and were supplemented with either 3 or 4-factor PCC, you see that the increase in thrombin generation that you are getting with those agents is not only for a few hours when your patient is bleeding, but for many days, at least 24 hours here. So that means that this brings us into this green box here when the patient is prothrombotic. So be careful with those agents because you might increase the risk a little bit. So this is some clinical experience. The first one on the top is Lisa Weiss-Barbarowski from Stanford, who actually described the use of factor 7 of FIBA, in patients who were undergoing unifocalization of tetralogy repair with major MAPCAs, and then fibrinogen concentrate and combined PCC in Austria with Corinna Willig-Schnaubler, who described not only the use of fibrinogen concentrate in PCC, but also the use of how they guide their therapy with viscoelastic assays. So those are two interesting standpoints of how to do it. This is the algorithm that was published by one of my friend and colleague, Moma Moumeni from Belgium, who described in her patients how she uses ROTEM, and as you can see, multiplates or functional platelet tests to guide their transfusion of FFP, but also fibrinogen, as you can see at the bottom there. Their dose is in between 50 to 120 milligram per kilo, which for 120 is on the high side, but otherwise a pretty interesting way of treating coagulopathy if you are interested. This is an algorithm that I designed when I was at the Hospital for Sick Children in Toronto. And this is not really a transfusion, it's not only a transfusion algorithm, it's also a toolbox that you can use pre-bypass, during bypass, and afterwards to decide how and when to treat coagulopathy. So you see that one of the things that we were doing is doing lab testing, and for some reason we were using standard coagulation test intra-op to have a platelet count, fibrinogen, and decide whether we wanted platelet, fibrinogen concentrate, or plasma. And on the right-hand side, you can see that when the patient was bleeding, we were assessing coagulopathy with the XTEM and the FIBTEM mainly, and deciding whether we wanted to have fibrinogen concentrate, platelet, or 4-factor PCC. I must admit that 4-factor PCC was rarely needed when you were applying this transfusion algorithm. One thing that we were looking at adding was the platelet function test. We did some studies on that, and we thought it was really helpful. But however, it's not something that is widely available in all cardiac programs. This is our transfusion algorithm here at Texas Children's Hospital. You can see that we send, not always, but we sometimes send a ROTEM when we were warm if we have doubt about the coagulopathy. But otherwise, when we have significant bleeding after protamine, we'll send a ROTEM, have a HEPTEM and a FIBTEM, and you see that our cutoffs there are for transfusion of platelets, fibrinogen concentrate with a dose of 70 milligram per kilo. We still use some cryoprecipitate, mainly in neonates, and then we have the option of using K-Centra or 4-factor PCC if the EPTEM is long, and again, not routinely using 4-factor PCC as much as the other products. So why is it important? Why are we talking about having those type of alternative to allogenic blood? It is because we know, and this is a recent study that was published in Pediatric Anesthesia a few weeks ago, an editorial that Louis Zabala, David Sutcliffe, and myself wrote. We know that the exposure of allogenic blood and the multiple exposures over time, which is really common in our pediatric cardiac population, will increase the risk of alloimmunization. And alloimmunization is a real deal when you have patients coming back with transplant and when you can't really get an organ that is a match for them because of all the antibodies that they have. So this is a real deal. I think we don't really know if reducing exposure to allogenic blood will reduce alloimmunization and improve outcome in transplantation. But still, I think transfusion is not free of side effect, and we have to keep that in mind. So in my conclusion, I think I tried to show you that we have to promote a targeted therapy of coagulopathy. I'm sure in this session, we'll talk about monitoring of coagulopathy a lot. And I was trying to show you is that the targeted approach is probably better than giving a lot of products of everything. Fibrinogen concentrate is a safe and effective alternative to cryoprecipitate, and I hope I convinced you that FFP is not an option to replace fibrinogen. There might be a role for 4-factor PCC, but we need to study it. We need some randomized controlled trial to assess not only the efficacy of 4-factor PCC in pediatric patients, but also the safety. And as I said, I don't think there's a role for factor 7A anymore. It's too risky. There's too many complications with that. I don't think FIBA is an ideal option either because the factor 7 is activated. But again, more studies are needed before we can address those questions clinically. So thank you so much again for having me. It's a pleasure to be here with you today. And I think we'll have a great discussion now.
Thank you very much, Dr. Favroni, for your excellent presentation. And now our speaker, great speaker, Dr. Christopher King. After graduation from Washington University, he started fellowship in anesthesia for organ transplantation, and he is currently working in National University Hospital of Singapore as the senior consultant anesthesiologist. Thank you very much. It's time for Dr. Christopher.
Hello and good morning. Thank you to ASPA for inviting me to speak today. I have received speaker fees from Werfen and Octapharma previously, but I have no conflicts to declare regarding this presentation. I've been asked to talk about the advantages and pitfalls of viscoelastic testing. While it's easy to speak about the advantages, pitfalls, which might also be thought of as hidden traps, are generally dependent on the user. I think by far the biggest pitfall is not completely understanding how viscoelastic testing works, the limitations and blind spots. This is not a minor thing. As our understanding of coagulation expands and the utility of VET broadens, it can be very difficult to fully appreciate VET in another clinical area or if you're an occasional user. There are more than 6,000 articles on VET, so I can only hope to give an up-to-date glimpse at what it can do. And for tradition's sake, I will mention some comparison to conventional coagulation tests, but much of the time it's a bit like comparing apples with oranges. Some of the slides have a lot of information on, but I'm assuming you will be able to review them later as you wish. There are now many different machines on the market. Newer ones often employ methods that don't require the formation of fibrin strands between a cup and pin. Using oscillations and optical or ultrasound measurement, they are able to detect changes in viscosity before fibrin forms, and, according to their manufacturers, provide more accurate measurement of clot elasticity. They may also have a greater range of available assays, such as the Clot Pro device. TEG and ROTEM are the main instruments being used and for which nearly all data and studies have been performed on. In the TEG 5000, the pin is suspended in the cup which rotates, while in ROTEM Delta it is the pin that rotates in a stationary cup. The TEG 6 and ROTEM Sigma use cartridges which have their pros and cons, and the TEG 6 also uses neuroclot resonance frequency technology. The main process is that whole blood is collected in a citrated sample bottle to prevent clotting. It's then micropipetted in the study cup containing the test reagent and then recalcified to initiate coagulation. The pin or cup is set to rotate at a rate representing low shear conditions of about 0.1 per second, which approximates to that in the vena cava, but much less than that found in venules, large veins, and the arterial system. As fibrin strands form between the cup and the pin, the rotation is impeded, and this is detected and displayed. Fibrinolysis will also be revealed as fibrin dissolves. If testing for hypercoagulability, then there's no need to use an activating agent. Use non-citrated blood and run the test, a native TEG or NATEM, but it needs to be done immediately. When testing for bleeding, then need to add an activator or the test will run for too long before any clot appears. Bleeding is urgent, so you need quick results, which is also why algorithms help, whereas they're not so necessary in hypercoagulability. Just as an illustration, the following is a short clip of coagulation viewed with the confocal 3D microscope following the addition of an activator. With a bit of artistic license, it gives some idea of what is happening in viscoelastic testing. Of note, there is no endothelium and there is no flow. You see fibrin strands and platelets. and the thrombin generation is obviously very quick, occurring at the beginning. The contribution that coagulation tests such as PT and APTT make to clotting have been likened to reading a child a story that begins once upon a time, but then ending it there. This clip also demonstrates the change from a liquid to solid phase, which begs the question, why use FFP, which is 95% water, if you don't have to? Simple comparison of point-of-care viscoelastic tests with laboratory conventional coagulation tests reveals many of their advantages. They use whole blood in a dynamic test, which has some similarity to in vivo conditions. Quick turnaround time means that they are suitable for use in vertical algorithms for emergency bleeding. Using a variety of reagents, they help diagnose and manage bleeding in general surgery, trauma, obstetrics, liver and cardiac surgery. They are also useful in predicting severe bleeding, a good example being FibTem results for PPH. New assays have been developed which are helping in management of anticoagulant and hypercoagulable states, such as sepsis and now COVID. Lab tests have good quality control, with results having a coefficient of variation of less than 5%. QC with VET using micropipetting are less good, but improved with cartridge systems. Finally, costing is complex. When considering total costs, including blood services, many report VETs are more economic, but this probably also depends on the system of health financing. Here, conventional tests and their respective VETs are shown loosely categorized against the stages of the cell-based model of hemostasis. CCT are usually considered to be the routine PT, INR, APTT, but have included other relevant tests. Neither CCT nor VET cover primary hemostasis involving platelet endothelial interaction and platelet activation. This is a significant blind spot of VET, which I'll return to. The PT and APTT test the extrinsic-intrinsic common pathways and are useful in monitoring vitamin K anticoagulants and heparin therapy. However, studies have shown that they have poor correlation with clotting times in viscoelastic tests, and in one report by Thorsten Haas, led to 50% more blood products being used. It is frequent with liver patients to find prolonged INRs with normal VET simply because they don't measure the anticoagulant aspect, such as antithrombin and protein C, as part of balanced hemostasis. VETs of new anticoagulants is an emerging field which I'll return to. I shall also elaborate on fibrinogen levels and VET functional fibrinogen. Ultimately, it rests on the premise that both reduced functional fibrinogen, either because levels are low or there is dysfunction, directly relate to poor clot formation and thence increased bleeding. I will also briefly consider platelet count and the platelet contribution to clot elasticity. Many studies report poor outcomes with platelet transfusion in various patient populations, particularly in pediatrics. A significant advantage of using viscoelastic tests is the possibility to substitute fibrinogen for platelets to achieve acceptable clot strength and avoid platelet administration. Factor 13 effects on VET are non-specific. Unfortunately, I will not have time to cover this here, but maybe in the Q&A session. Finally, I will also mention disturbances of clot lysis, which is another new area. I've coloured the topics I'll come back to later. Limitations and blind spots that can become pitfalls to the user can broadly be considered as user or device related. I think the issue that has the greatest potential for a pitfall is one of some knowledge or comprehension failure. This is often a result of inexperience. It seems the use of VET is inversely proportional to the distance to the machine. Considering the increasing complexity of coagulopathy and appearance of new data and assays, this issue is quite understandable. It's quite possible to miss something such as a heparin-like effect simply because you didn't run the test, perhaps even just to save money. It's also easy to overtreat, giving products because of an abnormal result when the patient isn't actually bleeding. For inexperienced users, it can be a challenge to trust tests such as a normal VET when the INR is deranged. It's also easy to forget basics. The VET device runs at a default of 37 degrees and the results may appear normal even though the patient is hypothermic. It's possible to reset the machine temperature, but I doubt anyone does. When acidosis is severe, it's worth considering correcting just for hemostasis. And hypocalcemia can result from citrate overdose from large FFP transfusion, which I've seen in the past in PICU. While the ranges for fibrinogen in pregnancy are well known, other population differences may not be appreciated. Fibrinogen levels increase with age. It's unknown whether the elderly patient with a fibrinogen of 3.5 will bleed at the same FibTem threshold as a 20-year-old with a fibrinogen of 2, and so be more tolerant of blood loss. And what are the acceptable numbers for something like a pregnant COVID patient with PPH? One of the commonest errors of interpretation is a FibTem result which is greater than XTem. It's impossible to aid for this to happen, and to aid interpretation, the University of Zurich have just developed an educational tool called a visual clot, which they report helps. Device-related issues are either a consequence of limitations or related to the assays and reagent used. The greatest limitation of viscoelastic testing is that they bypass most of primary hemostasis, and thus may give normal tests in the presence of conditions affecting platelet and endothelial function. In addition, VET measure global hemostasis and not what might be happening locally at the site of bleeding or thrombosis. Different coagulopathies are so complex, global function will likely miss the many nuances that might guide therapy. Assay and reagent related issues I will discuss individually as they include interesting new developments. Hopefully many of you will be familiar with the basic anatomy of a TEG or rotome trace, so I won't dwell on it, and you can always refer back to it later. Most are interchangeable apart from some of the lysis parameters. The first thing I'll look at are recent developments in using clotting times to detect direct thrombin inhibitors. While the XTEM CT is usually prolonged, it is non-specific, but this can be overcome by using new assays such as EcoTem and TFTem. So Ecoin is derived from snake venom. It's a procoagulant and cleaves prothrombin to mezzothrombin, which then activates clot formation. DTIs will inhibit mezzothrombin so that the EcoTem will be prolonged. Heparin has no effect on EcoTem as it can't actually bind to mezzothrombin. In the TFTem, there's 90% less tissue factor compared to the standard XTEM, so it's even more sensitive to drug inhibition of thrombin generation. EcoTem is currently not available outside Europe, but just to blow your minds even more, a group in Munich has just published a point of care guide for differentiating anticoagulant therapy using a variety of new assays, as you can see, and they claim a 98% accuracy in differentiating various anticoagulants. The second issue I'll look at is the validity of fibrinogen levels and VET functional fibrinogen assays. The problem with lab fibrinogen assays is that they measure fibrinogen levels regardless of function. For instance, levels can be normal even though function is affected by colloids or other causes of dysfibrinogenemia. The tests use plasma and therefore miss any effect of platelet activity and hematocrit on clotting, unlike viscoelastic tests. And also it should be remembered that fibrinogen is an acute phase reactant, so high levels may have little relation to clotting. The Klaus fibrinogen is often regarded as the gold standard. However, as you can see in this study, there are good reasons to question this. Where it's found poor within and between centre agreement. But it also boils down to what do we want to know? A snapshot level or a monitor of function. Some hematologists have criticised that FibTem may not correlate with fibrinogen levels, but really, so what? One thing to be aware of is that in the VET fibrinogen assays, platelet inhibition is not complete, which can lead to overestimation of the effect of fibrinogen on MCF or maximum amplitude. In the ROTEM FibTem assay, platelets are inhibited by cytokerasin D, which inhibits actin polymerization in the platelet cytoskeleton. The TEG functional fibrinogen uses abciximab, a monoclonal antibody fragment that inhibits the GP2B3A receptor on platelets. Cytokerasin D is a more effective inhibitor than abciximab. The ClotPro machine uses both inhibitors and achieves complete inhibition. There's also FibTem Plus, which also achieves this inhibition with cytokerasin D and tirofibam, but this is not commercially available. One other thing about cytochalasin D is that there's a slight independent procoagulant effect, so that the FibTem CT can be up to 7% shorter than the XTem CT, although this is not clinically significant. The third point I'll consider is the significance of the platelet count and interpretation of viscoelastic test platelet effect on clot elasticity, which is not quite so straightforward. Platelet count does not reflect patient function, platelet reserve in the spleen, and the consequences of platelet margination. A platelet sample may not reflect what is happening at the injury site or the effects of margination, and transfused platelets may be affected by the ongoing coagulopathy and become dysfunctional following transfusion. As mentioned earlier, viscoelastic tests don't detect primary hemostasis, platelet endothelial interaction, the possibility of von Willebrand disease or antiplatelet therapy. I don't have time to go into great detail, but platelets are the greatest contributors to clot strength and elasticity. However, this contribution is not simply XTem minus FibTem, and a closer estimate is the maximum clot elasticity calculated parameter. In this recent study in septic neonates, XTem amplitude gave the best correlation with platelet count and was also best at predicting bleeding events. However, of course, platelet count itself doesn't correlate with clot strength either. This final section will look at some of the complex issues around fibrinolysis, hypofibrinolysis, and hypercoagulability, which are also hot topics at the moment. Hypofibrinolysis is defined as impaired activation of the fibrinolytic system, whereas shutdown occurs after activation has taken place. On the other side, there is a spectrum through physiological lysis, increased fibrinolytic activation, to fulminant hyperfibrinolysis, whose severity often depends on its time of onset. Unlike conventional tests, viscoelastic ones contribute to understanding and managing these disorders. However, there are ongoing debates about the sensitivity of the machines, whether the phenomenon of fibrinolytic activation really exists or is clinically significant. This includes explaining how tranexamic acid can reduce blood loss when fibrinolysis is not detected on the viscoelastic testing. This schematic diagram depicts lysis, which results from increased release of TPA from endothelium and increased activation of protein C, which inhibits PI1, as well as cofactors 5A and 8A. Hypofibrinolysis is a kind of perpetuation of clot stability. Increased PI1 inhibits TPA, and increased activation of TAFI allows it to cleave lysine residues on fibrin, so that TPA and plasminogen cannot bind. The role of the thrombomodulin complex is critical. Viscoelastic tests can demonstrate hyperfibrinolysis in various ways, which you can look up according to your device. In severe cases, it can just be a flat line, but in others it might only be revealed using an antifibrinolytic assay, such as APTEM. Lysis onset time, or CLT, is usually the quickest way of confirming it. It's worth noting that in trauma patients, an XTem A5 of less than 35 millimeters identifies 90% of patients with hyperfibrinolysis. Measurement of functional fibrinogen, or FibTem, is the most specific and sensitive test of hyperfibrinolysis and is not compounded by clot retraction. Patients, especially pediatric, who become hemodiluted, are prone to hyperfibrinolysis. The most likely cause of this is dilution of endogenous antifibrinolytic proteins such as alpha-2 antiplasmin and factor 13. In this well-referenced study, plasmin-antiplasmin complexes were used as a biomarker of fibrinolytic activation. According to their definitions, this meant that moderate hyperfibrinolysis was associated with significant mortality, even though it was not detected with viscoelastic testing. However, the levels of plasmin-antiplasmin have not yet been validated, and isolated results which take time to process do not reflect the dynamics or the possibility of prior administration of antifibrinolytic therapy. This is just a reminder that a flatline ROTEM, or sometimes other skinny ROTEMs, can be due to causes other than hyperfibrinolysis. Note that excess FFP can result in citrate overdose, and that if you end up doing a NATEM, especially in septic patients, it needs to be tested within 3 minutes before it clots. One should also bear in mind that excess heparin, either exogenous or endogenous, can also cause a flat line if the viscoelastic test assay doesn't include a heparin inhibitor. Equally, if you don't test for heparin-like effects and only use X10-Fib10, which contain polybrine, then you can miss endogenous heparin as a cause of bleeding. Moving swiftly on to hypercoagulability, this can be due to a combination of hypofibrinolysis or shutdown with a procoagulant state manifest by shortened clotting times, which in sepsis is due to excess tissue factor expression on monocytes, and this leads to increased thrombin generation and clot strength. Increased clot strength is represented as MCF, but is probably more accurately shown on computer-generated parameters, especially G, which is more accurate at high amplitudes. Absolute cutoff values are still being determined, but trending of results in a patient are also relevant. The next few slides show how viscoelastic tests are being used to detect and contribute to the management of hyperfibrinolysis, hypofibrinolysis with fibrolytic shutdown, and hypercoagulability in sepsis, trauma, pediatric shock, and so on, shedding light on clinical areas where many conventional tests cannot reach. It is apparent that septic patients can flip between hyper and hypocoagulable states, which without viscoelastic tests might not be recognised. Viscoelastic parameters can also substitute for other biomarkers in sepsis, such as CRP, IL-6 or procalcitonin. Finally, COVID patients. In this Maastricht study, hypercoagulability and hypofibrinolysis were a major feature that also persisted despite routine anticoagulation. These various states have been put together as a triad. Using some of these parameters in septic patients can help identify patients at risk and potentially lead to timely interventions. For instance, D-dimers and lysis index can be used to start therapeutic anticoagulation. This slide demonstrates the viscoelastic parameters associated with increased tissue factor expression, a heparin-like effect, hypofibrinolysis, and hypercoagulability in a COVID patient. So I have almost reached the end of this whistle-stop tour of viscoelastic testing. I've presented some of the advantages and utility of VET in various settings and some things to be wary of. I apologise for an unintentional bias towards VOTEM, but this does seem to be where most of the data is coming from. I have not tried to justify these tests in terms of various outcomes. That would require reviewing the other 6,000 articles and also justifying conventional tests similarly. I have not mentioned platelet function tests, as these are not viscoelastic and are another enormous topic. But finally, I thought it would be useful to explore viscoelastic testing in the context of Asia and what the future may hold in the final two slides. In most wealthy countries, red cell transfusion needs are mostly driven by cancer anemia. This favours a centralised service with blood component therapy. Voluntary non-remunerated blood donation is the prevailing model. Patient blood management is the norm, and the use of viscoelastic testing and coagulation factor concentrates are one aspect of this. However, in much poorer countries, typified in sub-Saharan Africa, but also in parts of Asia, emergency bleeding predominates with malaria, trauma, obstetric bleeding, and sickle cell disease. This situation favours the use of fresh whole blood obtained locally and often met by family replacement donation, despite the goals of WHO. A common example of this being a mother donating to her child with malarial anemia. It is projected that by 2050, the global population will increase and shift so that 25% will be in Africa and 50%, down from 60%, will be in Asia. Demographic shift will also occur, now also driven by reduced birth rates due to COVID, so that there is an increasing elderly population who will presumably still suffer with cancer anemia. Although there will be an increase in wealth, low middle-income countries will still account for more than 4 billion people. A less cheerful projection is of further pandemics and never-ending turmoil from climate change. So of course, all kinds of developments can occur, but on current lines one can expect more cancer anemia, especially in Asia, an ongoing demand for red cells and platelets, an ongoing need to monitor and manage coagulopathy. One can expect increased use of viscoelastic tests or other new devices to be a part of this. You can see currently 430 of the 4,500 Rotem machines globally are in Asia. I do not have the data for TEG or other devices. It's quite possible that coagulation factor concentrates will replace FFP and cryoprecipitate. However, at the same time, there is a major strategic issue of plasma security. Plasma-derived medicinal products consisting of albumin, IgG and factor VIII have a global market and demand which is not met. The market is massively skewed towards the US, where 80% of PDMPs are derived from source plasma obtained from paid plasmapheresis donation in the USA. It is worth reflecting that no country, except maybe Italy, that practices voluntary whole blood donation, promoted by WHO as the only strategy, can produce enough recovered plasma to manufacture PDMPs. US source plasma is fractionated in the US or Europe, and PDMPs, including fibrinogen concentrate and PCC, are shipped around the world. A major consideration in producing PDMPs is the cost of fractionation plants at $70 million each. But at the moment, most of the world is critically dependent on the US for PDMPs and vulnerable to shortages however they might occur. Plasma is a universally available resource, but it is very expensive to mine. It will be interesting to see how this plays out.
And her main interest, pediatric and cardiac anesthesia and perioperative intensive care. And she's currently working in Siliat Hospital in Maidol University in Thailand. And we are so sorry for technical difficulties. And it's time for Professor Sunilat. Thank you very much for your understanding.
Good afternoon, Mr. Chairman, ladies and gentlemen. My name is Professor Sunilat Kongseripong from the Department of Anesthesiology, Silirat Hospital, Mahidol University, Bangkok, Thailand. I have to thank the Asian Society of Pediatric Anesthesiologists who invite me for this talk. My talk today is experience of viscoelastic testing in pediatric hospital. I don't have any conflict of interest associated with viscoelastic testing machine. As we know, viscoelastic testing is a method of hemostatic analysis that provides real-time holistic view of ex vivo clotting. VET can provide a more global view of hemostasis by displaying all phases of coagulation from clot initiation to clot lysis, which allow for more detailed and specific detection of coagulopathy. This is also help us to detect hypercoagulability state and severe hyperfibrinolysis that we are using a lot currently and associated with mortality of the patient. This test also be a point of care testing that we can test at the bedside or intraoperating room or at the laboratory lab. This use very small blood, about 0.3 cc per sampling, that is very compatible to the pediatric population. This helps for the rapid detection of coagulation disorder in the presence of excessive bleeding. This is a picture of a traditional viscoelastic machine. The first one is low-temp Alta, T25,000 and ClotPro. Two of these, low-temp and TG, has a lot of information for the pediatric population because it had been used before. And this is a schematic of the TG device that use very little amount of blood, 0.36 cc of whole blood, and with the torsion wire put with the pin into the whole blood. You can see that with this little amount of blood, they can have an error if you draw too small or too large of the blood. And if the machine not in the firm environment, so the result will not be accurate. The same thing that happened to the low-temp device. And this is the more advanced of the viscoelastic machine that use the resonant viscoelastic method. The first one is TAG-6A system that I use in my institute, and Sonocot and Quanta system. When compared viscoelastic testing and conventional coagulation test, you can see that VET test use rapid turnaround time less than 30 minutes, but anyhow is more expensive, about 5 times more expensive than the conventional coagulation test in my country. And this performed on whole blood, so no centrifuging was needed. That saved time. And also in my country, to save the money, we pull more sample for the conventional and then spin at the same time. That take long time for the patient and the result to come back. With many study report that when we use viscoelastic test, it associated with less product usage and better outcome in acutely bleeding patients. But anyhow, for the conventional coagulation test, this is a base to use as an anticoagulant screening test in the stable, non-bleeding patients. The viscoelastic test can detect hyperfibrinolysis, and only one device it can evaluate clotting factor, platelet, and fibrinogen, and more closely resemble in vivo hemostasis. And also this can measure the total clot strength. This is a schematic that helps us to understand that when we use the conventional method, for example, the PTT, it only associated with the initiation of the clot, but anyhow, the conventional method cannot tell us the strength, stability, lysis, and retraction of the clot. And anyhow, when we use the kind of machine, you need to know in detail what the result come back and what will be the error. For example, in my institute, we use the TG machine that all my residents who want to do the test need to know how to do the test exactly, has to be trained, and need to know how to interpret the result, that we put the report of this into the exam every year. And viscoelastic test and conventional clotting test are not interchangeable. And conventional clotting test might drastically overestimate the need of plasma transfusion in surgical and trauma setting. So finally, from the more recent, they favor the use of viscoelastic testing in the management of massive bleeding patients due to reduction of blood product utilization, bleeding, clot, and length of stay. How about in pediatric populations? Bleeding management strategy in neonates and children are mostly extrapolated from the adult experience and very little reference range for the pediatric population, especially less than 1 year. Anyhow, most of the maturation process can be observed during the first year of life. So in children over the age of 1 year, adult reference range for VET might be applied, like in my institute, that we hardly do the viscoelastic testing in the very young age. And we use the adult reference range for the infant older or equal to 1 year. And when we look in detail, the kids have more coagulation property, like they have the shorter R time and higher K time, a shorter K time, and the maximum cut amplitude was higher than adult. And we can use all tests of the ROTEM and TEG that used in adult can be used in the pediatric populations. How about in the pediatric with congenital cirrhotic heart disease? Because of the reduction in the plasma volume, so the result from the viscoelastic testing between the cirrhotic congenital heart disease was different from the non-cirrhotic congenital heart disease. So they are asking that we should have the reference range for the congenital heart disease that had cirrhotic and non-cirrhotic to prevent the error from this test. And also, when we look at the platelet function from the cirrhotic heart disease, it's not be as accurate as in adult. How about in my institute? My hospital is Siriraj Hospital from Mahidol University. We have more than 2,600 inpatient beds. Sometimes it's more than 2,600 beds, especially in the COVID era. We have more than 60 operating theaters. We do all kinds of complex surgery, including complex cardiac surgery, and 1/4 of them were pediatric surgery and pediatric congenital heart disease. As we know that when we do the cardiopulmonary bypass, especially in the pediatric population, they tend to have bleeding, probably from the cardiopulmonary bypass machine and delusional. And more reports, they show that ROTEM can help decrease of blood transfusion and also decrease the cost of the patient and length of hospital stay. Anyhow, from the meta-analysis and systemic review in 2017, they show that routine use of viscoelastic point of care testing does not improve important clinical outcome beyond transfusion in adult undergoing cardiac surgery, but this is in adult. Anyhow, from the report from the Sick Children Hospital in Toronto, they found that both TG and ROTEM is a technology that shows great promising for use in the perioperative management of pediatric cardiac surgery. This test can have an early detection of coagulopathy prior to separate from cardiopulmonary bypass, and also they can detect and predict those are high risk for thrombotic complication and prevent overtransfusion. This helps us a lot because especially in the cirrhotic heart disease that coming from shunt surgery, and if we overtransfuse, the shunt might be clot and the patient may have to come to surgery again. How about in my institute? We use viscoelastic testing in complex cardiac surgery and redo surgery for the kid older than 1 year of age. The problem is that we need the trained personnel to prevent the error with small amount of blood and machine. And this test was expensive, so we selected in only some of the patients, and the patient who use this test, we cannot reimburse even from the government. And currently, to prevent the bleeding, we use high-dose tranexamic acid, for example, 40 milligram per kilo before, during, and after cardiopulmonary bypass. We use modified ultrafiltration during cardiopulmonary bypass, especially at the end of bypass. At that time, we gave fresh frozen plasma about 20 cc per kilo combined with the red cell. And then we will filtrate the water out. And at the end, we left the platelet and cryoprecipitate to give at the end of the surgery. We early use a prothrombin complex PCC with a dose of 10 to 50 international unit per kilo and give carefully, slowly within 15 minutes per dose. And we forbid the use of hydroxyethyl starch and 4% gelatin during and post cardiopulmonary bypass. This is a picture of our cardiac operating theaters. We still use the conventional ACT machine. And for the small patient or neonatal patient, we use the small chamber so it can decrease the blood. And also we use the very short tubing that can prevent a lot of blood and so that come from the tubing. And even with the patient need to have the post-op ECMO, we saw very little bleeding with our policy. And we also use the transesophageal echo to help guide with the operation both in the neonate and infant. And this is a picture show that by the end that we use the modified ultrafiltration, we just need to give only the platelet and cryoprecipitate and left small amount of blood to give to the patient. And with the MAP policy that can filtrate out the cell or cytokine that can precipitate the bleeding also. And how about in liver transplantation? We did the liver transplant, the first one in the infant 6-month-old, and this patient also need redo transplantation in the next 4 days. At that time, we didn't use the viscoelastic testing. But anyhow, currently, we do a lot of living-related donor that have a lot of bleeding, and we use viscoelastic testing in many shots of the bleeding to help guide transfuse in this patient, and it really works. And how about for the twin separations? With the cellulose twin separation, but anyhow, we did not use the viscoelastic testing. Even we prepare for that because our twin just had some part of the heart and some part of the liver that attached together. So, and we used the special technique to prevent the bleeding from the cutting of the surface. So the kid not bleed a lot, and we didn't use the viscoelastic testing. And this one is about 6-month-old. And how about in trauma patient, we use some of the viscoelastic testing. The problem for us because of the trauma building was away from our main operating theater, and the viscoelastic testing machine was kept in our main operating building. So if we want to use it, we need to bring the machine and reagent from the center to the trauma building. That take some time. So we didn't use it often, but it really helped also. And as the information for this one, that in the pediatric trauma, the viscoelastic monitoring can help with the bleeding, even we use the breathing protocol. And currently, we use the viscoelastic testing in the pediatric patient who have to put on extracorporeal membrane oxygenations. This one, it can help both with the low temp and TG, And also we found that in the bleeding patient, when we use the viscoelastic testing, we use more cryoprecipitate. And we raised the question also that could this viscoelastic testing be used for titration anticoagulant, especially in the pediatric patient, because it's hard to give anticoagulant in this one, and especially in the patient who had a redo surgery with a lot of surface before, and also in the patients with the COVID-19 patients who had to put on the extracorporeal life support, that there are more to be thrombosis. This is a bit difficult event that we found in our country recently. This is the patients when they came back from surgery and they had to put on ECMO. And recently, we do cytokine removal, especially in the COVID-19 patients, that can help with the storm, cytokine storm, and help heal the patient more. We hardly see the patient as you see in the pictures, but cytokine removal also help more. And at this point, to prevent a lot of bleeding, because at this time we are shortage of blood, because rarely patients donate the blood at this COVID-19 era. So with this testing, it helps us to prevent giving the blood and blood component to the patients. Anyhow, as we know that with the COVID-19, they had a lot of incident of thrombosis. So by using the viscoelastic testing, they can help us predict the thrombosis of the patient. And I believe that in the future, they might help us to guide giving anticoagulant to these patients. So in my experience of viscoelastic testing in pediatric populations, I use it in massive bleeding surgery, for example, complex pediatric congenital heart disease that who come for surgery either in the first time or especially when they do the redo surgery. Pediatric liver transplants, especially for the living-related donor that we need to cut the liver, and major spine surgery, and the pediatric who has to put on extracorporeal membrane oxygenations. I use it for the patients over or equal to 1 year because I use the adult range. I told my colleagues that when you use it, because it's expensive and we use a small amount of blood, so I told them not to do multiple testing, especially in young age. So what viscoelastic testing helped me? This test helped me guide what I should be give to the patient during massive bleeding. It really helped during massive bleeding. And I retest after the treatment instead of I have to send the blood to the lab. And if it not correlate with the clinical, I believe clinical, I have low threshold to transfuse in the cyanotic congenital heart disease, especially in the palliative surgery, because they still have cyanosis. And if it's still bleeding, I talk to the surgeon to have him look at the surgical bleeding. And if it did not help, I will consult the hematologist. In conclusion, the use of viscoelastic testing-based transfusion algorithm offer a feasible approach and had been shown to improve bleeding management and rationalize blood product transfusion in adults and children. And I believe more information of the fusion of the children is coming more and more. Anyhow, when you use it, because this is expensive and have a lot of error that can happen if we are not carefully. Specific algorithm should be used based on the patient age, comorbidity, for example, cardiac or liver disease, and the type of surgery performed. Thank you very much for your kind attention. I'm happy to answer the question. เป็นไงกี่นาที
I think we have some questions on the chat.
Yeah, we have some questions from the audience. And I think these questions for Dr. Favrani. What's the dosage bolus or infusion dose of PCC for pediatric patients? First question. And second, is there any difference for newborn? Thank you.
Thank you for having me today, and thank you for the question. So the dose that we usually use are in the range of 35 unit per kilo to 50 unit per kilo of PCC. I personally use it as a slow infusion over 5-10 minutes. The question about is there a difference between neonates? I think there might be, but we don't know because there's absolutely zero study in neonates. Which is basically the population where we use the PCC probably the most, at least in my experience, where we have all the Norwoods and stage 1 procedures that are usually the bloody one. So I think it needs to be studied, but in my experience, we use 35 to 50 units per kilo.
Can I come in here and add, with our liver patients, we usually start at something much lower, like 7.5 or 15, because if there's any thrombosis, for sure, the PCC will get blamed for it. So we start off with that and then do another ROTEM and see what the outcome is.
And another... Sorry,
I'm impressed that they let you use PCC in liver transplant. That's very impressive. They didn't even leave me use TXA in liver transplant.
And okay, another question. When we have no viscoelastic testing available, and when is the proper time to give PCC and fibrinogen? And are there any amount of bleeding kg per kg for bleeding amount or minimum allowable blood loss?
So those are very good questions. Number one, I'll start with the third one. I don't think it's easy to measure milliliters per kilograms of bleeding intraoperatively. At least in my experience, I never really managed to have an accurate measurement of that. So I think most of the time we use visual impression on how wet the field is, and in discussion with the surgeon to know how they feel about hemostasis. In terms of if you don't have viscoelastic test and you don't routinely send standard lab test, I think you can estimate in a way what the fibrinogen level would be based on whether you replaced it or not. So what I'm saying here is, for example, if you have a 7-kilo baby coming for VSD repair and you don't use FFP in your prime, well, you can estimate that your fibrinogen level will be probably on the low end. So if you have bleeding, you might think about fibrinogen. The use of PCC, I think, in any cases, whether you have viscoelastic test or not, should be left as a last resource when you've given platelets and you've given fibrinogen and your patient is still bleeding. So I don't feel strongly about having a viscoelastic test to guide PCC. I think it's more of a resource that you use when the patient is bleeding, despite all the things that you've given.
Okay, thank you very much. Another question.
Can I throw in a question here? So it does seem like coming off bypass, the main blood products that we do give are platelets as well as PCC, and FFP is not really in consideration at this stage. Is it the reason? Is it volume or?
It depends on what you. I think it depends on what you have available in your institution. I think in my experience, we use FFP a lot on bypass to prime, and so I don't feel like I have a need for FFP at all. As I usually say, I use FFP when it's as a volume replacement strategy in a really bleeding patient. So it's more of a situation where you massively bleeding, you need volume, you need coagulation factors, and so I would use FFP rather than crystalloids or colloids. But to treat coagulopathy, the issue, as I said, is if you want to increase a specific factor with FFP, and I think Dr. King said that too in his talk, it's mainly is very close to water. So you have to give quite a bit of FFP to see an effect. So I would say volume when you have coagulopathy, yes. Treating a specific coagulation factor deficiency, maybe not.
Mm-hmm. I think there was. Oh yes, Prof. Yes, we would like to hear from you too, Prof.
Yeah, we did a lot of very little congenital heart disease. What we did in my institute to prevent the bleeding, we used high dose of pancinemic acid. Currently, we use about 40 milligram per kilo that we give to the patients before bypass, and then in the bypass machine and after bypass. At the end of the bypass, especially in the procedures like arterial switch that have a lot of bleeding, we do muff. That before or after the muff, we give FFP at the time we do the muff. And after that, we load the patient with tranexamic acid and PCC. We use a lot of PCC, starting from 20 to 30 international unit per kilo. And then we go with the platelet 20 cc per kilo and cryoprecipitate 20 cc per kilo. And if they still have some kind of bleeding after we reverse the protamine, we keep more of the PCC, the less of the uh, 30 international unit per kilo. In 15 minutes, we used to have a patient die intraoperatively with the fast bolus of the PCC. Since then and after the conference, we did not give any PCC anymore. And for the viscoelastic testing, because it's very expensive in my institute, and we need very accurate because it's just 0.36 cc in the diluted unit. So we hardly do it except in the ICU when we transfer the patient in the ICU or when the patient is on ECMO and we saw a lot of bleeding and then we do the TG after that.
Can I add something about PCC that I think people should be aware of the long half-life of the factors? And when you get a patient who's bleeding a lot and then you keep replacing the PCC, you don't know how much has bled out and how much is retained, and then you'll end up with potentially a prothrombotic patient post-op. And there's some suggestion that we should be monitoring things like antithrombin to know that heparin is working and that sort of thing. So
yeah,
if you have a patient who continues to bleed, then you've got this problem of how much PCC have I given and how much more should I give?
Usually, the maximum that we gave it is not higher than 50 milligram per kilo. That is the maximum that we use it. We also use in the older kids and in the adult population when we do the aortic surgery, and then we wait for about 6 to 8 hours before we can give more of the PCC. Currently, we use a lot in my institute, but we combine with the tranexamic acid also, and it really helped us a lot, and help us save the blood component, especially in the COVID era. We have a very few donors. We are shortage a lot of blood. The surgeon said that if you want to do surgery, you need to find someone to donate the blood for you. Otherwise, we will not do that surgery.
So Prof, with your use of PCC in your institution, how often do you see thrombotic complications?
Very few, just only one patient that they bolus 50 milligram per kilo immediately, and we saw the clot in the coronary artery right away. And since then, we brought that issue into the conference. And since then, we kept it in 15 minutes and diluted in 5D water to be like 20 to 50 cc and keep it very slowly. So be patient with the bleeding, not be too much if you want to use the PCC.
Right. Okay. I think there was another question in the chat group as to are there groups of cardiac patients you will not give PCC, or groups of patients in that sense you will not give PCC?
In my institute, with the shunt surgery, especially with the congenital genetic heart disease, we will not give PCC. If we think that they will have any kind of thrombosis, the surgeon discuss with us, and then we will not give it. Or even the Fontaine surgery that they have a slow anastomosis, we will not give the PCC at all.
Dr. Faroni, you wanted to say something?
No, I would just say, in my practice is to tend not. I try to avoid PCC in coronary arteries work in neonates, just because we've seen some issues with that. So I don't use PCC as much as Professor. I probably use it 10 times a year maximum. So it's really in a limited population where we have excessive bleeding. And I would be careful with patients at risk of thrombosis.
I think we also have one. I think there was I think Kevin in the chat group actually is mentioning there's a lot of resistance of PCC use in children, and he's asking any guidelines I can use to discuss with my pharmacist and transfusion medicine team.
Not in children. So the only guidelines that you will see in children, and we wrote one of them, we didn't recommend the use of PCC because there's not a single study. So I think it's based so far. If you look at the literature in pediatric patients, you'll see case reports, case series, but you won't see any trial or any guidelines that recommend the use of PCC.
Yeah, they don't have any guideline, but 3 years ago we went to the critical care meeting in Brazil, and since then, at that time we had a lot of problem with the bleeding with the pediatric cardiac surgery, and then we start using it. I think we have informations that let's say after this meeting we will gather the information and maybe might report to the world about using the PCC in the pediatric cardiac surgery. And currently we are collecting the data, combining the use of the PCC and high dose of the tranexamic acid, and review retrospective only the high dose tranexamic acid for about 1,000 records, only tranexamic acid, but about 100 records about the combined PCC and tranexamic acid. Let's say if the result coming, we are going to report to the world also. But we didn't see any problem at all. Frankly, we didn't see any problem if you use it carefully. And I agree that with the coronary in the pediatric patient, like in our ASPA, that's we didn't use it. We talked to the surgeon. Even arterial switch, we use it, but we didn't see any problem if we keep it very carefully and don't to keep it often.
Can I ask David what his doses of tranexamic acid are? Because I remember asking him way back in a NATA conference, and I think he's using higher doses than we routinely use in our surgeries.
We use I use a 30 milligram per kilo loading dose and 10 in children that are less than 1 year of age, and then above 1 year of age we use 10 milligram per kilo and 10 milligram per kilo per hour. So it's a bit on the lower side, I think, compared to many American programs that still use 100 milligram per kilo. And the decision that we made based on the 30 and 10 and 10 and 10 was based on the pharmacokinetic studies that were published in the last 5-6 years.
And have you seen any complications, any side effects?
Well, the only side effects that is described extensively in the literature is the seizure, which I personally haven't seen. I think it's challenging to see seizures in our pediatric patients, especially when you keep them sedated afterwards. It's been described. I think it's probably there are some data on dose of tranexamic acid and plasma level and level in the CSF, which shows that if you go with high dose, and when I say high dose is 100 milligram per kilo or above, you increase your risk of seizures. But at the doses that we use, I can't say that I've seen seizure ever, at least not related to TXA.
So outside of cardiac surgery in general use, do you think that the doses that are often given in trauma and etc. are kind of homeopathic doses? It's sort of
well, in adult trauma or
a pediatric is 20 milligrams per kilo, and then 2 milligrams per kilo per hour. They seem very low in comparison.
I think that the loading, if you use 10, 20, 30, I think it's more than enough. What I'm worried about is some people have really decreased their infusion to, as you said, 2 milligrams per kilo hour. And that's really, really small. And I think what you see with the pharmacokinetic data is when you use a 2 milligram per kilo per hour infusion, you're really, really at the borderline level. And as you said with PCC, it's true for TXA too. If your patient is bleeding, you have TXA leaving as well. And so in those cases, you probably get into levels that are way too low. So I think the loading dose, if you look at 10 milligram per kilo, you get really decent plasma concentration. And I think infusion, I rarely go down below 10 milligram per kilo per hour.
Mm-hmm. Thank you.
Yeah, in my practice currently we use a 40 milligram per kilo loading, and then we also give it in the pump 40 milligram per kilo and another 40 milligram per kilo after the bypass. We did not see any problem with the seizures, and with our chart review in about 1,000 patients that I'm going to report, we saw only one kids that had seizure, but that not correlate with the tranexamic acid. But in the past, we used only 10 milligram per kilo. In my institute, we did not infuse into the pump because we used to see clot into the pump. At that time, since then, we are afraid to use the tranexamic acid infused into the pump. But I think it's quite safe. In our last study, that about 40 milligram per kilo. Let's see. I'm going to report that very soon, probably in the next 2 months.
Okay, we just waiting for everybody to come back on screen.
Hi again. And I would like to thank all speakers and Angela, despite of all technical issues, make this session really successful. And thank you very much for everything. We can talk many more topics and questions, but we have no time. And I have already some questions, but next time, I hope. And thank you very much for all speakers' excellent presentations. And thank you, Angela.
Yes, thank you very much. Thank you, Aiden, for being my co-moderator today. I think we had a very good discussion just now during the Q&A session, and already in my work chat group, we've already have some noise and some discussion going on already. Thank you all for your time, and thank you all for being here today. Okay, so I'm just gonna do some housekeeping. This is we're trying to set up a pediatric cardiac special interest group as part of the ASPA umbrella. So any of you who are interested to join, please scan the QR code and leave your details, and we will contact you. Also, there is a social program that is happening at 5:30 p.m. Singapore time. I would like to invite all of you to join the social program if your time zone allows, that is. Thank you, Dr. Farmi. I know that's very late on your side already. I should not hold you any longer. I really would like that we can meet up sometime in person at some other conference, hopefully in the near future. Thank you all.
Thank you.
Thank you.